Hello, thank you for joining us today for the ICRN Translational Science Seminar Series. My name is Donna Mayer. I'm introducing Dr. Keri Lunsford today. Our topic is Innovative Surgical Approaches to Cholangiocarcinoma, Transplant and Beyond. Dr. Lunsford is the Assistant Professor of Surgery and a Liver Transplant and Hepatobiliary Surgeon on faculty at Rutgers, New Jersey Medical School, and she's also a member of the Center for Immunity and Inflammation. She received her MD and PhD degrees from the Ohio State University, completed surgery residency at Duke University, followed by her fellowship at UCLA. Prior to joining the faculty at Rutgers, she played a key role at Houston Methodist Hospital in the groundbreaking protocol for liver transplant for intrahepatic cholangiocarcinoma, and she's also internationally recognized as an expert in this field. She is also well published in the field of transplant surgery and immunology. Welcome, Dr. Lunsford, today.
Thank you, Donna, and I'd like to thank the ICRN as well as the Cholangiocarcinoma Foundation for inviting me to talk today. I think there's going to be virtual questions at the end, so if you guys come up with any questions along the way, if you want to type those into the chat. And I will go ahead and get started. Maybe. So as most of you all on the conference probably know, cholangiocarcinoma has a very grim prognosis if it's unresectable, with an expected survival of 6 to 12 months. Unfortunately, only 40% of patients are resectable at diagnosis. And of those patients, approximately 70% of all comers will have some sort of a recurrence after resection. The challenges that we see with surgical resection is that there can be infiltration beyond the radiographic extent of what you see on the pre-transplant or the pre-surgical imaging. And oftentimes it's located near critical structures such as the major portal vein branches, the hepatic hilum, and as well as the hepatic artery. So liver transplant can offer an alternative to resection in select patients, given that at least theoretically it can achieve tumor-free margins, it treats the parenchymal invasion, and it can remove underlying tumor. So as you all know, intrahepatic cholangio are those which occur within the liver and the small biliary ducts within the liver itself, whereas hilar cholangiocarcinomas occur at the confluence of the hepatic ducts and the common bile duct. Distal cholangiocarcinomas may also occur. However, those distal cholangiocarcinomas are not indications for liver transplant, and I will not be discussing those today. So the incidence of cholangiocarcinoma, especially intrahepatic cholangiocarcinoma, has been on the rise in recent years. And it's currently considered to be the second leading cause of liver cancer under HCC. In terms of liver transplant for hepatic malignancy, there are multiple indications which have been recognized for liver transplantation. And those which are recognized as indications, patients receive what's called a MELD exceptions. They receive extra points to prioritize them on the wait list so that they can have sort of an equivalent chance of getting transplanted as those patients who are being transplanted based on their liver disease. So hepatocellular carcinoma is probably the most commonly recognized oncologic indication for transplant. However, perihylocolangiocarcinoma is also a recognized indication, as well as metastatic neuroendocrine tumor and hepatoblastoma in pediatrics. There are some additional indications which are currently under investigation, including intrahepatic cholangiocarcinoma, which we're going to discuss today, as well as metastatic colorectal cancer. And the indications for liver transplant, especially with the advent of the hepatitis C drugs, which have decreased the amount of transplants that we're doing for hepatitis C virus, viral-induced cirrhosis, the transplants for malignancy have substantially increased over the past few decades, with malignancy now being one of the primary indications for liver transplantation. I'm going to focus first on discussion of perihylocolangiocarcinoma. So risk factors for perihylocolangiocarcinoma tend to be advanced age, male gender, and especially in primary sclerosing cholangitis, which is one of the most common indications that we see as liver transplant surgeons for liver transplant for perihylocolangiocarcinoma. It's also seen in colorectal cysts, cholelithiasis or gallstones, cholecystitis, parasitic infections, inflammatory bowel disease, chronic pancreatitis, as well as other indications for cirrhosis and metabolic syndrome. And those shown in red are ones that we commonly also see underlying liver disease and indications for transplant. Perihylocolangiocarcinoma can be mass-forming, periductal infiltrating, or intraductal. And the classification of the different of the locations for perihylocolangiocarcinoma depends on whether or not, or can dictate whether or not we can do a resection. So especially in these type 4, bismuth type 4 lesions, where they're involving both the right and left hepatic duct, really there's not going to be a way in which we can reconnect the bile duct surgically in order to just resect one lobe of the liver. And so in those cases, transplant is most likely the best option. And then depending on the extent for the type 3 and type 4, may determine whether or not a patient can receive a liver transplant versus a resection. So when we're evaluating patients for transplant, or even actually for resection for perihylocolangiocarcinoma, one of the things that's key in our evaluation process is an ERCP in order to obtain brushings as well as a FISH. For that diagnosis. This can also evaluate through cholangiogram the ductal extent of the disease. It can identify if the patient has some underlying PSC or multiple bile duct strictures seen throughout the biliary tree. Therapeutic stenting may be possible. But the most important thing is that we can obtain brushings and sometimes even a spyglass directed biopsy of a mass within the duct, which is especially important in a patient who might be a candidate for a transplant, because you want to avoid transperitoneal biopsy and seeding of the tumor. And actually, according to the current transplant guidelines, performing a transperitoneal biopsy actually excludes a patient from being able to be considered for liver transplant. Cholangioscopy may also be performed for a targeted biopsy of the lesion, as I discussed. And as well, we usually will do an endoscopic ultrasound on patients, especially those who might be transplant candidates, because you need to evaluate the perihilar and gastrohepatic lymphadenopathy. And any time that we see a lymph node which is increased in size, we will do an FNA biopsy of those in order to exclude lymph node metastases, which would be a contraindication for transplant. We also usually do a high or dual energy, high resolution 4-phase CT scan with very thin cuts. We have this deemed at our institution as the cholangiocarcinoma protocol. We will accept an MRI if it's a very high quality MRI and needs to have triple phase with portal venous phase and arterial phase, as well as delayed imaging on that as well. This differs from the liver protocol CT scan in that it adds the delayed phase, and it's critical for surgical planning as well as for identification of metastatic disease. The disease extent is often difficult to distinguish in low quality scans, and so oftentimes we may even have to repeat the CT scan in order to better distinguish the extent of the tumor. It also allows us to identify intrahepatic masses, biliary vascular encasement, as well as lymphatic disease. We need to add a chest CT scan for staging, and we also need to add a pelvis CT scan for staging, which is necessary for our evaluation for metastatic disease, especially in patients who might be transplant candidates. For patients who are being considered for transplant, because it's so important for us to rule out metastatic disease prior to transplant, I usually also like to add an FDG PET. It's not critical for the diagnosis. However, I have found PET positive lesions on patients that we didn't have other indications that they had potential metastatic disease. The intrahepatic cholangiocarcinomas actually tend to be a little bit more PET avid. So definitely on any intrahepatic cholangiocarcinoma patients, I usually will get a PET. Higher it tends to be if their CA19-9 is very elevated, or if I have concerns that there might be disease elsewhere that we're not identifying. And then during the pre-transplant laboratory evaluation for cholangiocarcinoma, either intrahepatic or for hilar cholangiocarcinoma, we do general laboratory testing, including LFTs to monitor their total bilirubin. And this is useful to ensure that the patient doesn't have some obstruction, which is critical for us while we're evaluating the CA19-9 level. We do check tumor markers, and I tend to get the full bevy of tumor markers, including AFP, CA125, CA, and chromogranin A. I find the AFP very useful, especially in sort of a mass-forming lesion, or in the case of patient who has underlying cirrhosis, because we do see hepatic cholangiocarcinomas commonly in those patients, which can sometimes be confused or even misdiagnosed on biopsy as an intrahepatic cholangiocarcinoma. The other thing that's critical for our evaluation is to get an IgG4 level in order to rule out autoimmune cholangiopathy, because this can very commonly be misdiagnosed as a cholangiocarcinoma, and the prognosis of the two is significantly different. So with IgG4 associated autoimmune cholangiopathy, the clinical presentation can be very similar. Patients will present with jaundice, extrahepatic biliary stricture, bile duct wall thickening, peribiliary inflammation, and they can even have pseudomasses. And I've seen patients that have been operated on by some colleagues for presumptive cholangiocarcinoma and had a major liver resection, in which case the postoperative diagnosis comes back as autoimmune cholangiopathy. The process normally almost exclusively involves the extrahepatic bile ducts, which can differentiate from primary sclerosing cholangitis. And predictors include pancreatic abnormalities, gallbladder involvement, or if we see continuous biliary involvement, we can often be suspicious. Most patients will have an elevated IgG4 level, and most patients can also be treated and will improve with steroids or immunosuppression, and would have a non-operative surgical or non-surgical approach to management. So to get on to transplantation for perihylocolangiocarcinoma. So this was initially reported, the first case that I've seen in the literature was by O'Grady in 1988. He reported a series of 26 patients who were transplanted, and the survival outcomes were fairly poor, with a 38.6 survival at 1 year, and all patients had expired by 4 years. However, when looking back at the outcomes from this evaluation, the initial outcomes were likely poor due to patient selection. The patients who were selected had fairly poor tumor biology, such as perineal invasion, poor differentiation of the tumors. They were also chosen to be transplanted at a very late stage of the disease, when there was oftentimes already metastases present, or they were doing resection of multiple organs at the same time in order to manage more extensive disease. There was also the lack of consistent use of neoadjuvant therapy in these early studies. So why is recurrence so high after a liver transplant? So the specific pathologic things that can be seen are perineural invasion, lymphangiosis carcinomatosa, which can extend, which is the sort of a infiltration of the tumor up to 2 centimeters into the liver and the hepatoduodenal ligament. There's a high rate of microscopic infiltration beyond the visible and palpable extent of the tumor, and transplant for late stage disease with prior lymph node metastases, as well as lack of consistent protocols for adjuvant and neoadjuvant therapy. So in 2000, the Mayo Center, the Mayo Clinic published their outcomes, 2012, the Mayo Clinic published their initial outcomes for liver transplant for perihylocolangiocarcinoma. And they established what's now known as the Mayo Clinic criteria, or the Mayo criteria. And this is what we're currently using to this day for selection for our patients for liver transplant for perihylocolangiocarcinoma. This dictated that they had to have an early stage hyalocolangiocarcinoma with diagnostic criteria, including malignant appearing stricture or mass with one of the following, either malignant cells on biopsy or cytology. And again, this has to be a transbiliary biopsy, not a transperitoneal biopsy. Positive aneuploidy on FISH, or a CA19-9 of greater than 100. Although I know that the majority of centers will actually use 150 as their cutoff for CA19-9. The patient also needed to have unresectable disease due to liver disease or mass location. If the mass was present, it had to be less than 3 centimeters in radial diameter, and there could be no lymph node metastases, and biliary sepsis needed to be controlled. And this is important, especially if you're using CA19-9 as part of your diagnostic criteria, because anytime patients come in with a biliary obstruction, they'll have an elevated CA19-9 just from virtue of having obstruction of their biliary ducts. In addition, there can be no intrahepatic cholangiocarcinoma, and as I've stated, I think a couple times now, no prior transperitoneal biopsy or prior surgical resection, although the patient may have had a remote history of a laparoscopic cholecystectomy or an open cholecystectomy. Once the patients meet this criteria, then they're enrolled to undergo a fairly intensive neoadjuvant treatment regimen, including external beam radiation of 4,500 gray and 30 fractions plus 5 FU. They've also received intrabiliary brachytherapy of 2,000 to 3,000 gray and 5 FU, as well as after receiving that, they then have to undergo an exploratory laparoscopy with evaluation to ensure that there's no peritoneal metastases, as well as a biopsy of the perihylar lymph nodes to ensure that the lymph nodes are negative for malignancy. Patients are then kept on oral capecitabine until the time of transplant. So here, looking at a CT image of the hilum, and this patient does have a stent in, so you can see the bile duct here is bright white. This is a 1.9 centimeter or 1.94 centimeter radial diameter of the mass. So we're talking about the radial diameter of the tumor and not the longitudinal size. There's actually no limit on the longitudinal size of the tumor. With the initial Mayo outcomes, the outcomes for liver transplant were actually very good, and their initial series evaluated transplant versus resection. And for transplant, they saw a recurrence rate of 13% for liver transplant versus 27% for resection. There was an overall improved survival over resection. However, the patients who were selected for this initial group were fairly highly selected, and many had fairly early stage disease. And of note, there was 42% of patients who on Explant Pathology had a complete pathologic response. Predictors of recurrence appeared to be lack of pathologic response on explant, as well as pre-transplant portal vein encasement. The center went on to then evaluate multi-center retrospective evaluation of a 12-center consortium of 287 patients receiving liver transplant for cholangiocarcinoma, which was either within Mayo criteria of being that the mass was less than 3 centimeters, or beyond Mayo criteria, which was a mass greater than 3 centimeters. And they found that the outcomes for liver transplant in terms of recurrence-free survival were 69% for patients within Mayo criteria compared to 32% for patients who are outside of Mayo criteria. And this really established liver transplant for perihylocolangiocarcinoma as a potential indication, because generally our threshold for something being considered to be an acceptable indication for liver transplant is that the recurrence-free survival and the overall patient survival for the indication needs to be greater than 50%, so that you're using your scarce liver resource most ethically. So there is a difference, and this may also explain as to why some of the results, especially with the early Mayo study, were so much better than what was seen in the larger study. There is some difference in liver transplant for de novo cholangiocarcinoma versus PSC-associated perihylocolangiocarcinoma. So with PSC-associated perihylocolangiocarcinoma, there's a lifetime incidence of 6.8 to 13%. Patients tend to present at a younger age, and because they're screened so regularly, they often have an earlier stage at diagnosis, but it also is often more likely a multifocal disease. It's very difficult to get pathologic diagnosis on these patients, and so oftentimes these are patients that are diagnosed without necessarily a tissue confirmation, but based more on the presence of this dominant stricture with elevating CA19-9 or FISH positivity. The patients, however, tend to have a much higher rate of survival after transplant, with 75% of patients being alive at 5 years. In contrast, de novo cholangiocarcinoma may more likely be resectable at the time of transplant, but patients tend to be older when they present, and the tumors tend to be larger as well. These patients tend to have a 5-year survival after liver transplantation of 56%, and these outcomes are more comparable to what we see with an R0 resection for tumors that are of similar size. Recurrence after liver transplant for perihylocolangiocarcinoma, majority of patients will have more of a local recurrence, with 62% of recurrences occurring within the liver. We do see recurrence of 42% near resection lines or in regional lymph nodes, as well as peritoneal metastases. Extrahepatic metastases most likely occur within the lungs. So when we're doing surgical therapy, so I want to now switch to intrahepatic cholangiocarcinoma and discuss that a little bit more in depth as well. So really the gold standard for intrahepatic cholangiocarcinoma, and this is in contrast to perihylocolangiocarcinoma, which for which transplant has become relatively well accepted. Surgical therapy is still considered to be the gold standard for treatment for intrahepatic cholangiocarcinoma. Recurrence of cancer after resection is dictated by the tumor size, the nodal status, differentiation, as well as the degree of vascular invasion. And the indications for a patient to be able to be resectable is that they have to have no extrahepatic disease. Ideally, there's no distant nodal metastases. For patients that have a lymph node metastases that are outside of the perihilar and gastrohepatic ligament, really the survival following resection is going to be no different than what we would see with just chemotherapy alone. Patients should have ideally a solitary lesion. There is an increase in the risk of recurrence for patients who have multifocal disease or satellite nodules. However, select patients who have 2 to 3 lesions may also be resectable. They also need to have an adequate future liver remnant, and this is very important, especially in patients who may have some underlying liver disease due to NASH or a PSC or some other type of liver disease such as hepatitis C, as we need to make sure that they're not going to go into liver failure following the resection. So if you look at the surgical outcomes by Explant Pathology, this was a recently published sort of nonogram, or decision tree, which describes the overall recurrence after surgical resection for intrahepatic cholangiocarcinoma. And you can see that those patients who have small tumors, which are more mass forming as opposed to infiltrating tumors, tend to have the greatest 5-year survival, with a 5-year overall survival of 61%. In addition, even if a patient has a single lesion or 1 to 2 lesions and it's an N0, they can have a 5-year survival of up to 45% as you get to larger tumors or the infiltrating type of tumor. You see much lower 5-year survivals with 0%. For multifocal tumors greater than 2, you can see a 5-year survival of 10%. In addition, patients who tend to have a in-one disease or an R1 resection tend to have a lower survival. So the question has been evaluated in at least a limited basis as to whether or not neoadjuvant therapy is useful for surgical resection in intrahepatic cholangiocarcinoma. And I would say probably the jury is still out. The majority of patients who present with intrahepatic cholangiocarcinoma will receive upfront resection. However, I think the data does suggest that there might be some role for some upfront chemotherapy in a specific group of patients. So the two larger studies that have evaluated this was Buettner in 2007, published in the Journal of Surgical Oncology, did a evaluation of 62 patients with intrahepatic cholangiocarcinoma compared with plus neoadjuvant chemotherapy compared to 995 patients who just had upfront surgery. R0 resections were more common in patients who had upfront surgery, but the morbidity and mortality and overall disease-free survival was similar between groups. In 2018, British Journal of Surgery, Leroy and colleagues presented 74 patients who received neoadjuvant chemotherapy plus plus resection for intrahepatic cholangiocarcinoma compared to 112 patients with upfront surgery. Only 53% of patients who were initially evaluated who had locally advanced disease and were not immediately resectable were ultimately resectable. And however, even though the patients who received received neoadjuvant chemotherapy for downstaging to resection had more advanced disease initially, they were more likely to have an R0 resection. And the morbidity and mortality and overall and disease-free survival were similar to those patients who had had upfront surgery. So although there's not going to be a definitive survival benefit for receiving upfront neoadjuvant therapy for patients who sort of are at the borderline of being resectable or who are who might have a disease which could be near some critical structures, I think that it's reasonable to do upfront chemotherapy in those groups. Currently, with some of the newer chemotherapeutic agents, there is a prospective randomized clinical trial through Emory that's a multi-center trial which is evaluating GAP therapy or gemcitabine, cisplatin, and Abraxane for perioperative downstaging for locally advanced biliary tumors. And with some of the outcomes that they've seen with downstaging with GAP therapy, I believe that people are very hopeful that this will be a promising new weapon in our arsenal. So if patients are not candidates for surgical resection, then the alternative is generally medical therapy, and this would be the gold standard for unresectable disease. So for patients with intrahepatic cholangiocarcinoma, which is liver only versus non-liver only, there's really not a very significant difference in survival, and without any treatment, patients have a survival of 5.2 months, whereas it's significantly increased with the gemcitabine and cisplatin therapy to a overall survival of 16.7 months and a progression-free survival of 11.1 months. Other options in addition to systemic chemotherapy can include the alternative chemotherapies. The one which is currently enrolling for phase 3 study is the gemcis and Abraxane or GAP therapy, which extends median overall survival to 19.2 months. And you see a 45% partial or complete response rate, which is why people think this might be a good alternative for patients for they're downstaging for surgery. And you see a median progression-free survival, which is improved to 11.8 months. Other alternatives which have been evaluated in fairly small studies include protein beam therapy, hepatic artery infusion pumps, which both can offer up to 22 or more months of survival, as well as improved response rates, TACE therapy, as well as Y90 therapy. We've looked at the SEER database for the outcomes of liver-limited intrahepatic cholangiocarcinoma to determine what the difference is for patients who specifically have disease that might be transplantable. So this is T1, T2, or T3 disease based on the AJCC 6th edition. This is equivalent to the current definition of T1 or T2 disease, but they had changed the staging system with the AJCC 7th edition. And also patients had to have N0 or M0 disease. And we looked at the differences in chemotherapy or chemotherapy plus radiation compared with a surgery. And we see that surgery alone versus surgery plus medical therapy offers no specific survival benefit. However, surgery does demonstrate a significant survival benefit over chemotherapy, either alone or in combination of medical therapy plus radiation. So what about liver transplant? Because, as we discussed sort of early on, liver transplant was not necessarily an early indication for liver transplant, but later studies demonstrated that there was feasibility within a specific patient population. So historically, similar to what we see with cholangiocarcinoma, the outcomes for liver transplant for intrahepatic cholangiocarcinoma are fairly poor, with an overall survival at 10 years of 20%. And that's sort of below that 50% threshold. However, this changed in 2016 when Gonzalo Sapasosyan published an international multi-center retrospective study, which collected the data from 17 multinational centers. And this was retrospective data from these centers for any tumors that were incidental at the time of transplant on explant pathology, or they were misdiagnosed prior to transplant as hepatocellular carcinoma in cirrhotic patients. Many of the patients within the study did receive local regional therapy because they had actually been diagnosed with HCC mistakenly on their pre-transplant imaging. And they actually, in order to sort of consolidate things, they excluded any patients who received neoadjuvant therapy other than local regional, TACE or RFA. They separated patients or stratified patients into two different groups, one being a very early intrahepatic cholangiocarcinoma, which was a single tumor of less than or equal to 2 centimeters, or advanced intrahepatic cholangiocarcinoma, which is a single tumor of greater than 2 centimeters or multiple tumors. And what they saw is that for the advanced group, results were fairly consistent, although actually a little bit better than what had previously been reported for cholangiocarcinoma. For patients with tumors of greater than 2 centimeters, the relative risk for, the cumulative risk for recurrence was about 60%, and the overall survival was slightly less than 50%. In comparison, for tumor recurrence, for the very early group, they saw about an 18% recurrence rate with an overall survival of about 65%. So that would be within the margins of acceptable for transplant. Many people think that the 2 centimeter criteria for patients for transplant for intrahepatic cholangiocarcinoma might be a little bit too narrow, because it's very difficult for to obtain a diagnosis of intrahepatic cholangiocarcinoma when the tumor is that small. But these are mostly patients who have a background of cirrhosis. And so patients are getting screened much more regularly. They according to the guidelines, they should be getting some sort of abdominal imaging at least every 6 months. So for So the French group actually did a subsequent study, which was very similarly designed, which is a retrospective analysis of patients who had incidental or local regional treated intrahepatic cholangiocarcinoma, and they compared their results with surgical resection. Because they felt like the criteria that had been outlined by the Barcelona group was too small, they actually extended this to include cholangiocarcinomas, which had a cumulative diameter of 2 to 5 centimeters, so including some tumors which were multifocal. And they saw an overall survival of about 60 to 65% for patients for liver transplant, compared to a 5-year overall survival of about 30% for patients who had undergone liver resection. And this was not significantly different based on the numbers of patients that were available. And in terms of recurrence-free survival, they do see an almost significant difference or improvement in recurrence-free survival for liver transplant over liver resection. So this suggests that although 2 centimeters looks like it's probably a good place to start, it's possible that we may be able to extend our criteria to select patients with slightly larger tumors for liver transplant in the setting of just local regional therapy on a background of cirrhosis. But what about chemotherapy? So, the data, especially the historic data for intrahepatic cholangiocarcinoma and liver transplant, has been very difficult to interpret because this is a relatively rare cancer and a relatively rare indication for transplant. Many of the studies actually combine the results for intrahepatic cholangiocarcinoma and hilar cholangiocarcinoma, and we see actually the same thing in a lot of other studies for biliary tract tumors, such as the studies that we see for chemotherapy trials. In order to be able to get an adequate power for a study to be able to show an effect, you have to incorporate multiple different pathologies in your study. But it doesn't necessarily make things clear cut, especially if there is a possibility that the biology of the tumor and how they're metastasizing and how they're reacting to transplant may be slightly different. So one such study is a study out of UCLA, which performed a retrospective evaluation of 43 patients who underwent liver transplant for known cholangiocarcinoma. Of this, 26 patients had intrahepatic cholangiocarcinoma and 14 patients had perihylocolangiocarcinoma. What they found on multivariate regression analysis is that an intrahepatic location and pre-transplant neoadjuvant therapy were associated with improved outcomes. Now, it's very difficult to interpret what this exactly means, but it did give us an idea that potentially adding neoadjuvant therapy for selection of patients for transplant may be a possibility. When we look at the SEER outcomes, again, this is a very small number of patients who have been reported in the SEER database, but patients who received transplant alone and the SEER database had a survival which was similar to what was seen with surgical resection, whereas those patients who underwent transplant plus chemotherapy appeared to have a slightly improved overall survival comparatively, although we don't have enough patients with 13 patients in that group to reach statistical significance. So in order to further evaluate this, we actually sought to do a prospective evaluation of liver transplant for intrahepatic cholangiocarcinoma, and this is work that was done while I was at Houston Methodist Hospital in conjunction with MD Anderson. And so we looked for patients in order to select our proper candidates for transplant. We selected patients who had prolonged disease stability in response to chemotherapy, thinking that this may be criteria for us to select biologically favorable intrahepatic cholangiocarcinomas for liver transplant. So our criteria were that patients had to have stable disease of greater than 6 months, and they were required to continue on neoadjuvant therapy until the time of transplant. They needed to be stable during that time. So our specific criteria included biopsy-proven cholangiocarcinoma. So we did require that patients have a transperitoneal biopsy of the intrahepatic mass. The mass had to be located within the liver itself. They could not be amenable to surgical therapy. There could be no evidence of extrahepatic disease, including lymph node disease. So we did perform EUS evaluation on many of these patients. We did allow patients to have a prior resection, but if they had a prior resection, they had to have it had to be at least 6 months prior to listing, and all of the other criteria needed to be met. The diagnostic criteria we required were very similar to what we see with Perihylocolangiocarcinoma, including triple phase CT scan of the chest, abdomen, and pelvis. We did an MRI bone scan on patients, as well as an FDG PET and an EUS guided biopsy of enlarged nodes. Patients then received neoadjuvant chemotherapy. The majority of patients received first-line platinum-based chemotherapy plus gemcitabine. If patients had progression or intolerance, they were switched to a second-line chemotherapy, but then they had to be stable for 6 months at least on that second-line chemotherapy. And we did allow for the addition of targeted biologics on a case-by-case basis. Patients were required to then have disease stability for at least 6 months on any given regimen. They received repeat imaging every 3 months. And we noted radiographically stable or regressing disease as a requirement during that entire course. So if they had any disease progression while they were listed, then they would be put on hold until disease stability could be achieved by some other means. And then there could be no extrahepatic disease. Post-transplant, depending on the tumor, the explant pathology, the majority of patients received adjuvant chemotherapy for 4 to 6 months. And if there was any tumor or any residual cancer left, patients were required to receive this. So looking at the experience as of the end of 2019, when I left Houston, there had been 41 patients who had been referred for evaluation. Of these, 14 patients we excluded due to extrahepatic disease. 5 patients who were referred for transplant were able to actually either downstage or resect. 1 patient was medically unacceptable due to underlying cardiac disease. We had ongoing evaluation of 2 patients, and 19 had been listed for liver transplant, of which we transplanted 11. Now, since I've left, they've actually transplanted an additional 6 patients from this group, including some of these patients who were awaiting transplant actively when I left. So 2 patients who were listed for transplant were further downstage. We had to abort 2 of the transplants due to severe adhesive disease due to the extent of prior radiation therapy prior to transplant. 3 patients were actively awaiting transplant, and 1 patient was delisted due to disease progression. Looking at these tumors, these were definitely unresectable tumors. As you can see, one of the patients had a very large central hepatic mass, which was unable to be resected. Other patients had multifocal and bilobar disease, but these weren't necessarily small tumors. We weren't limiting tumors based on size, but more on the disease biology and the stability of the tumors. Looking at the demographics of the patients, the first 11 patients that were transplanted had an age of 46 years, relatively small BMI. The majority of patients were white. We actually had 27% had underlying primary sclerosing cholangitis, and they had very low MELD scores. So this is sort of problematic in this group because this is still considered to be an investigational cause for transplant. We don't receive MELD exception points for these patients. So the option for where to get donor, the concern is where can we get donor organs for these patients? Many patients end up being listed for a fairly long period of time and having a significant burden of chemotherapy prior to transplant because we are searching for basically a liver that would otherwise be discarded for them. In 2 cases, we used what's called a Domino liver transplant, which is a liver that we were taking out of a patient and transplanting a new liver into that patient for some sort of metabolic liver disease. In a couple patients, we used DCD grafts. Some patients received livers from especially old donors, but these were basically donors that had been turned down for every other transplant center in our region. Post-transplant, our median follow-up has been, or our median follow-up at this time is 59 months, and patients had a fairly reasonable post-operative length of stay of 10 days. Looking at the intention to treat analysis for patients who are listed for locally advanced intrahepatic cholangiocarcinoma, of the 17 patients that from that initial group that were listed, 11 patients underwent transplant, and 6 patients were ultimately delisted, 2 because of further downstaging, 2 because of abortion, because the procedure was aborted due to transplant, and 2 were delisted due to disease progression. And as you can see here, of the patients that delisted, the majority of the patients were dead by 18 months, whereas patients who were transplanted had a 5-year survival of 87.5%. So there was a significant difference there in terms of outcomes and intention to treat. Looking at the survival for liver transplant patients, and this has sort of evolved from the initial 6 patients that we had published back in 2018. We have an overall survival for the first 11 patients of 79.5%. As I mentioned, 6 additional patients for a total of 17 have now been transplanted, and the additional 6 patients are all within the first year of, or all within about a year of transplant, but none of them have any evidence of recurrence to date. There were, especially early on, there were 4 patients who had fairly early recurrence after transplant. The majority of these patients actually recurred within the first 12 months, and I'm going to discuss them here in a minute. And then we had 1 patient who developed a late recurrence. However, of these patients that recurred, this person who had a late recurrence, as well as 2 of the additional patients here, actually survived for greater than 5 years. So they still maintained long-term survival despite the presence of recurrent disease. Looking at the explant pathology for these patients, we see that there was a total, a fairly large tumor size with a total diameter of 8.5% on median, maximum tumor size of 6.5 centimeters, and many of the patients had multifocal disease. We have not been able to identify any particular things which have correlated with recurrence as of yet, with the exception of the presence retrospectively of extrahepatic disease prior to transplant. So a few of the patients that we transplanted had notations after we sort of went back and reevaluated their imaging that there may have been disease present outside of the liver prior to them being selected. So of these patients, and this is the 5 patients who recurred, of these patients, 1 patient had a recurrence of 4.1 months. She had recurrence at the lung, and she was seen when we went back and looked at her imaging. There were stable lung lesions, which were too small to characterize at OLT. After she came off chemotherapy, post-transplant, those progressed and she developed lung masses, but she was able to survive for greater than 5 years. Another patient had recurrence at the lung, liver, and bone, and she had actually had a bone lesion which was too small to characterize at the time of transplant. They tried to do a biopsy on it and were unsuccessful at getting any tissue, but she recurred at 7.6 months and then died at 14.4 months post-transplant. And then another patient had a recurrence at 9.7 months. And he, on his explant pathology, had a positive perihilar fat margin, and then ultimately developed a local recurrence within the omentum, but also was able to survive for greater than 5 years. And then the last patient with the early recurrence had a recurrence of the rectus sigmoid junction, and we had actually done a PET CT scan on him, which showed an area near the in the colon that had been PET avid. However, we had performed a colonoscopy and hadn't seen anything there. Unfortunately, I think the MET was actually right at the peritoneal reflection. And he recurred and died at about 2 years post-transplant. Our late recurrence recurred in the thoracic spine. He's been receiving treatment and is doing very well with ongoing survival of greater than 5 years. So if we look at the patients that don't have extrahepatic disease at the time of liver transplant, our survival is actually 100% with a recurrence-free survival of 66%. So really the biggest question is, can we better identify these patients that have extrahepatic disease prior to transplant? And I think we're getting better at it, and we're a little bit more suspicious. But I think that's really going to be one of the critical things for us for choosing the proper patients. The other thing I think that might end up being important is the role of tumor genetics and tumor biology. As you can see here from the genetic sequencing that was done on the first several patients, some of these patients actually have targeted opportunities for targeted therapy, such as IDH1, BRCA, FGFR2. We saw FGFR2 in a number of the patients who received transplant and did fairly well. So this tends to be sort of denote a better biology. Whether this is significant will require additional patients for us to determine. But as I said, there are multiple agents that are potentially available, which those of you who are oncologists who are on the call probably know much better than I do. Intrahepatic cholangiocarcinoma tends to have a fairly high mutation burden, and so it's very worthwhile for sending the next generation sequencing on our patients at the time that they get the biopsy. And I actually routinely will request it and send an NGS panel at the time that I evaluate them for transplant if it hasn't been done already. So basically, intrahepatic cholangiocarcinoma, I like to think will be ultimately an acceptable indication for transplant in select patients. Right now, this is limited primarily to research studies. However, I think the data is pretty good for the cirrhotic patients with very limited tumor burdens, may be treated with local regional therapy and amenable to transplant. Non-cirrhotic patients with liver-limited disease who demonstrate response to chemotherapy, I think should at least be referred for consideration for transplant if they are not resectable. And hopefully we will gain additional evidence throughout the years that this is an acceptable therapy. Patients with advanced intrahepatic cholangiocarcinoma that we transplanted despite a large tumor burden have excellent overall survival and acceptable recurrence-free survival. I suspect that as we progress, these outcomes will be better. And I think that pre-transplant evaluation or identification of extrahepatic disease is key. Interestingly enough, our outcomes actually exceed what's previously been reported for liver resection. However, if a patient is a candidate for liver resection, I would still preferentially do a liver resection for them versus doing a transplant. We need to have a better understanding and do more research into tumor biology to better understand which patients may be selected and for us to be able to better target these tumors for perioperative therapy. There's currently a multi-center clinical trial underway for evaluation of this, of which Rutgers is a member. And I just sort of, in the last couple, and just very quickly sort of want to present one case of a patient with unresectable cholangiocarcinoma, because really this is a multimodal, multifaceted approach. Some of these slides are courtesy of Bruno Odisio at MD Anderson. This is a patient that we collaborated on and ultimately transplanted. So 38-year-old gentleman who had no history of prior liver disease. He presented in 2016 with intrahepatic cholangiocarcinoma. As you can see here, a very central lesion, and received 3 cycles of gemcitabine cisplatin. He then underwent a right trisegmentectomy, which means they took out all of the liver except for the left lateral segment, for those of you who aren't surgeons in the audience, and then receives Xeloda following his resection for adjuvant therapy. Unfortunately, 2 years later, he showed up with a new lesion in his liver remnant. This was treated with additional gemcitabine, cisplatin, and Abraxane, and he did have some response. And then underwent by Dr. Odisio, he underwent irreversible electroporation in June of 2018. And then subsequently with another metastases, which was identified, he underwent Y90 therapy, and there you can see it metabolically active. And then when they were doing a hepatic angiogram as a follow-up, they noted 3 additional lesions, which were again subsequently treated. And then the patient was also started on, he had an IDH1 mutation, and so he was started on an IDH1 investigational agent, and was able to achieve 6 months of tumor stability. We then did his transplant at the beginning of January of 2019. This is the explanted liver here. As you can see, it doesn't look all that great. And it's a new liver, which looks very nice. On explant, there was a complete pathologic response. And this is actually the only patient to date that we've seen a complete pathologic response on. You can see some of the areas of fibrosis, which represented the treated tumors. You were also able to see on the explant histology, the Y90 microspheres with red areas consistent with areas of prior tumor response. And to date, he is about 2 years out now with no evidence of recurrent disease as of the last time I was able to check. So I'd like to acknowledge everybody who's contributed to this work, to put a shout out for evaluation for patients for the clinical trial, for any patients that you might think might be a possible candidate. And I'm happy to take any questions in the chat.
Dr. Lunsford, it
Yes.
looks like you have a message from Kristen Spencer.
Okay.
What do you see being the route to meld points in these patients? Further trials?
Yeah, I mean, I think we're going to have, hi, Kristen, how are you? I think we're going to have additional clinical trials for these patients. You know, I think I'm actually currently sitting on the guidelines committee for the AASLD for the cholangiocarcinoma guidelines. And basically, you know, back the last 10 years ago when the guidelines were last written, the recommendation was absolutely not intrahepatic cholangiocarcinoma should not ever be considered an indication for liver transplant. Currently, I think our recommendation that we've settled on after much debate is that you know, this is something that we can consider it for small tumors, and that it should be evaluated for patients with larger tumors in the setting of a clinical trial. So I think we're going to need to have some additional trials or a larger scale study, you know, sort of like what we saw with the Mayo experience, because the Mayo experience for hilar cholangiocarcinoma was not actually a multi-center clinical trial. They didn't have the funding for that. So it was multiple centers that did a similar protocol, and they combined their data. You know, these are very difficult trials for us to get funded sometimes. And, you know, right now we're having difficulty for getting you know, livers for these patients. So the other option is potentially living donors. And so some of the centers that are in the trial are actually using living donors for those, because those patients do not need MELD exception.
Okay, thank you. I encourage everyone who's on the webinar to enter your questions in the chat feature if you have any. We have another question from Marie McNamara. She wants to know, when you say smaller tumors, what size are you referring to?
So smaller tumors at present, the best data is for tumors less than 2 centimeters for intrahepatic cholangiocarcinoma. I think the French study looked at tumors up to 5 centimeters in cumulative diameter with fairly promising results. But it's a lot, it was less centers that were involved. So I think that still requires some additional evaluation and some validation from data from other centers.
Okay, another question from Talia Baker. The role of modified immunosuppression and adjuvant therapy post-liver transplant. What is that?
Yeah, I think I understand what you mean, Talia. So in the patients that we treated, and you know, the data regarding the modification of immunosuppression therapy is especially, you know, most of what we know is with hepatocellular carcinoma. Our protocol in Houston, as well as the protocol that I've implemented at Rutgers, is to do after 1 month post-transplant, we switch patients to low dose Prograf and everolimus, and we try to run them fairly low on their immunosuppression, so usually in the 3 to 5 range for each. I have seen 1 or 2 patients. I did see 1 patient that ended up with rejection, and you know, I've been very interested in better assays for analyzing the robustness of the immune system so that we can better control this and we can better tailor immunosuppressions. And that's part of what we're looking at in the lab.
Okay. Does anybody else have any questions to post now? Okay, I don't think so.
Okay, I was going to say one other thing. So if I didn't put it on this slide, I really should have. But if anybody ends up coming up with a question, my email is Keri. I spell my first name KERI.Lunsford@Rutgers.edu.
And they can also contact me if
Yes.
they need that information. I'd be happy to share that. So thank you, Dr. Lunsford, and thank you to all of the participants on the webinar today. The webinar will be posted on the CCF website and on YouTube. And we appreciate your participation. Thank you.
Thank you, everyone.